the approach to cough and hemoptysis. This is a recorded lecture since I have a preceptorial class at the same time as this lecture, but I will still go online at the end to answer any of your questions. So you may send them anytime during this lecture and I'll address them at the end. So this would be our objectives for today, and I will be discussing the normal physical exam and PE findings for some common respiratory diseases. There are a number of common respiratory symptoms that can be discussed, but for the sake of this lecture, I will be focusing on cough and hemoptysis and their clinical presentation of the common diseases that can cause them. And at the end of this session, you should be able to recognize the common clinical conditions and their usual manifestations and physical exam findings. To start, the general technique in doing the physical exam of the respiratory system will include your inspection, palpation, percussion, and auscultation. It goes in this order except when you are doing your gastrointestinal examination, wherein the inspection and the auscultation goes first to avoid altering the findings if you percuss and palpate initially. You also need to be able to identify these anatomic landmarks on the chest, anterior and back, in order to properly document your physical exam findings. And these landmarks correlate with certain locations of specific visceral structures. Like, for example, the sternal angle of Louis. This correlates with the bifurcation of your trachea into the right and left main bronchi. It is also at this angle that the costal cartilage of the second rib is attached to. So the other landmarks to take note of in this slide are your suprasternal notch, the xiphoid process, and the costal angle. You also need to properly label your intercostal spaces and your ribs. We have a total of 12 ribs. The first 7 would articulate individually or separately to the sternum. The 8th, 9th, and 10th would articulate with the cartilage above them, and the 11th and 12th are your so-called floating ribs. The ICS, or your intercostal spaces, are named according to the rib that is superior to it. On the anterior chest, you can also see the angle of Louis uh, and use it as a starting point in counting the rib and the intercostal space number. Posteriorly, landmarks to take note of are your spinous process for C7, which is the first prominent protrusion that is felt when you flex your neck. Below that is a T1 spinous process, while the inferior angle of the scapula corresponds with the location of your 7th rib or your 7th intercostal space. We also use our imaginary vertical lines to guide us in our localization of our physical exam findings. Anteriorly, we had the mid-sternal line, which just runs along the sternum, the mid-clavicular line, which drops from the midpoint of the clavicle, and your anterior axillary line, which drops near the lateral end of your clavicle or the anterior axillary fold. Laterally, we see again the anterior axillary line with your mid-axillary line, which drops from the apex of the axilla, and your posterior axillary line, which drops from the posterior axillary fold. Posteriorly, we have your vertebral line, or the so-called spinous line, and the scapular line, which drops along the inferior angle of your scapula. You need to remember that your lungs are asymmetric, and the right lung having 3 lobes, while the left lung has 2 lobes. Both lungs, however, have the oblique fissure or your major fissure, which separates the lower lobes to the other lobes. This runs from the T3 spinous process at the back, then goes around your chest obliquely downward to the 6th rib at the mid-clavicular line area. You also have your horizontal minor fissure found at the right, which separates the right middle lung and the right upper lung. This runs close to the fourth rib from the anterior portion, then meets at the oblique fissure at the mid-axillary line at the level of the fifth rib. So if you do your physical exam, the adventitious breath sounds on certain area would likely be localized to the underlying lobe. So for example, you have a prominent auscultatory finding on the anterior chest. This would likely correspond to the anterior facing lobes, namely your right upper lung, your right middle lung, and your left upper lung, with small portions of the right lower lung and left lower lung projecting anteriorly at the inferior portions, while posterior auscultatory findings would correspond to either the upper lung or the lower lung. But you have to remember that there are certain overlaps between the placement of the lobes. And so that is why you need to supplement your physical exam findings with an X-ray for a more specific localization of the diseased portion of your lung. And when you request for a chest radiograph, always make sure that a frontal and lateral views are ordered, not just a frontal view. Auscultatory findings on the lateral side of the chest could also be roughly localized to certain lung lobes. On the right lateral side of the chest, when you hear apical adventitious breath sounds, this could be localized to the right upper lung, while basal adventitious breath sounds could be localized to the right middle lung if anteriorly heard, or to the right lower lung if posteriorly heard. So on the left lateral side of the chest, the anterosuperior portion lies the left upper lung, while the postero-inferior area contains the left lower lung. Auscultatory sounds can also be localized to the airways, and you have to remember that breath sounds and adventitious breath sounds are two different categories of sounds. Adventitious breath sounds are always abnormal, while breath sounds are usually normal depending on which part of the chest you hear them. So breath sounds heard along the trachea are different than those that you hear on the large airways, smaller airways, and on the alveolar area. So having the knowledge of which part of the airways you're listening to is essential in differentiating the breath sounds. So along the manubrium and the initial parts of the sternum lies the trachea. And the trachea bifurcates into the right and left main bronchi at the level of the T4 spinous process posteriorly and at the angular fluid at the anterior portion of the chest. If you look more closely at the right main bronchus, it is more vertical and wider than the left main bronchus. Hence, aspiration mainly falls in this area for ambulatory patients and for those that can stand up or sit up. At the neck area, the accessory muscles can be prominently seen for patients with an increased work of breathing, namely your sternocleidomastoid muscles and your scalene muscles. So when you prominently see these muscles in your patient, then it gives you an idea on the severity of the respiratory distress that the patient is experiencing. The respiratory examination starts with the inspection of the chest and its movements, and we also observe for the presence of any deformities or asymmetry. We look also for signs of respiratory distress, as discussed earlier, with the use of accessory muscles or visualization of your intercostal space retractions, which are most noticeable in pediatric population and in thin patients. So if you observe that there is an impaired respiratory movement on one side, then you need to confirm it by palpating and doing your chest expansion, as seen here in this slide. So when you do this, you put your thumbs at the level of the 10th rib, then apply medial pressure to make a small skin fold and ask the patient to inhale deeply. And as you observe, you look for the range and symmetry of the rib cage. You can also do your chest expansion on the anterior chest, done in the same way as before, but here the placement of your hands should be on the subcostal margin. These are some of the common examples of unilateral delayed expansion, and this would include fibrosis of the lung parenchyma, fibrosis of your pleural cavity, the presence of a massive pleural effusion, or a consolidated pneumonia. Bronchial obstruction could also impede the expansion of the affected unilateral lung, and the presence of a paralyzed hemidiaphragm could also have a delayed expansion. Under palpation, you could also check for symmetry of the tactile or vocal fremitus or vibration. So when you ask the patient to speak, the sound creates a vibration that is transmitted from the airways or the source to the chest wall. So normally, this is felt more prominent on the central areas near the source of the sound than the peripheral areas of the chest. So as in here in this slide, the central areas are labeled 1 and 2, while the peripheral areas are labeled 3 and 4. You use your ball or ulnar surface of your hands to feel for the fremitus or vibration. And you compare simultaneously the left and right on a step ladder approach, starting from the first area, going down to the fourth area. And if with asymmetric fremitus, take note of the areas with increased or decreased or absent fremitus. In the anterior chest, it is also recommended to do a stepladder approach for consistency. So starting from the top on the first area, going down to the third area, as in here in this slide. Increased transmission of the vibration can typically be seen in consolidation pneumonia. And so for cases with decreased transmission, this can be due to air in the pleural cavity or water in the pleural cavity, or due to a thick chest wall, due to a muscular body, or a thick adipose tissue. An obstructed airway could also lead to a decreased or absent tactile fremitus, also including tumor infiltrating the airways, which can impede the transmission of the sound. When you do your percussion and auscultation, this is the recommended systematic approach. You start off at the apex, then move to the contralateral side of the same level, after which you go down just one step, then move to the contralateral side at the same level. Still a step ladder approach as before. Just take note to avoid areas where there is a decreased transmission of sound, namely your spinal areas, your scapular area, thick muscular areas, and at the breast area. Percussion gives you an idea of whether the underlying superficial tissue is whether air-filled, giving you a hyperresonant or tympanitic note, fluid-filled, giving you a flat note, or consolidated, which can impede sound transmission, hence giving you a dull note. As seen here in the image on the left, only one distal interphalangeal joint should be placed firmly on the interspace when doing your percussion. No other part of the hand should be touching the patient's chest because it will dampen the vibration. And you strike the interphalangeal joint attached to the chest with the other hand, and the movement should be aided by the wrist and must be sharp and brisk. Oh, this is a table that shows the different percussion notes, their characteristics, where they can be normally heard and abnormally heard. And the best way to familiarize yourselves with the sounds is to percuss your own body. Your normal lung would give off a resonant sound while your thigh would produce a flat sound, which is also found in patients with pleural effusion and a massive pulmonary edema. While your empty stomach or a puffed out cheek would produce a tympanitic sound, as with patients with large pneumothorax. There are some instances where more than one percussion sound can be heard. A typical example of this would be a hydropneumothorax, wherein there is water and air both in the pleural space at the same time. But since water is more dense than air, then water would settle on the dependent portion of the lung. Hence, you would hear a dull sound at the base, while air, being less dense, would rise up to the independent portion of the lung. Hence, you would elicit a tympanic sound at the lung apices. These are the breath sounds or lung sounds that are normally heard with the stethoscope. And the breath sounds correspond to the movement of air in and out of the lungs from the trachea up to the lung parenchyma. The tracheal breath sounds, which are centrally located and best heard in the neck, are harsher and louder than the one those heard more peripherally. So as you go from central to peripherally located breath sounds, the sounds would become softer and with a lower expiratory pitch. Bronchial breath sounds come from the tracheobronchial tree or from the larger proximal airways and is best heard over your manubrium. The broncho-vesicular sounds are the transition between the vesicular and the bronchial breath sounds and is best heard on the first and second intercostal space and between the scapula, while your vesicular sounds are heard all over the lung fields. However, be mindful that not all breath sounds are normal, because breath sounds would be abnormal if you would hear it on a location that is distally located than where it is normally heard, because that part of the lung may be fluid filled or consolidated, which enhances the sound transmission, which is basically the same concept as seen in cases with increased tactile fremitus. On the other hand, you should always consider adventitious breath sounds as abnormal. So we have crackles, wheezes, and rhonchi. Crackles are intermittent non-musical sounds, and you have your fine and your coarse crackles. Fine crackles are soft, high pitch, and heard in the middle to late inspiratory phases, indicating opening of the collapsed airways. Examples of this would be found in patients with atelectasis and consolidated pneumonia. You also have your coarse crackles, which are loud, low pitch, and heard in the early inspiratory or expiratory phases, indicating opening of collapsed distal airways due to secretions. So the quality may change after patients coughing or suctioning their secretions. Then we have wheezing and rhonchi, which are both continuous musical or whistling sounds. Wheezing has a high pitch and hissing quality, indicating the narrowing of the distal airways, which are typically presented with patients with COPD, asthma, bronchitis, or any intraluminal airway lesions. Rhonchi, on the other hand, are low pitch, snoring in quality, and indicate secretions in the large airways, which may also change in quality after coughing or suctioning. Another adventitious breath sound not seen in this slide is your stridor, which is high pitch and is loud enough that you can hear it even without a stethoscope. And it's noticeably loudest during inspiration and is best heard along the trachea. And this would indicate the possibility of an upper airway obstruction due to a probable spasm, stenosis, foreign body aspirations, or a intraluminal tumor. And you should avoid mistaking stridor for wheezing, because the management differs greatly and we might not give the necessary life-saving measures for the patient. And it, unfortunately, mistaking stridor for wheezing is common among general practitioners. So for normal lungs, as a review, with a patent airway and with no airway secretions, breath sounds would be predominantly vesicular with absent adventitious breath sounds. The spoken words would be muffled. The spoken E would be heard as E. The whispered words are distinct, and that is because air impedes the transmission of these words, and the tactile fremitus would be normal. On the other hand, the presence of pneumonia with thick secretions, pulmonary edema, or blood within the airways and alveoli would enhance the transmission of sound and vibration. And in these diseases, the lung parenchyma is relatively now denser than a normal air-filled lung. Hence, the bronchial or the bronchovesicular breath sounds would be heard more distally than they are typically heard. Spoken and whispered words would be louder with the presence of egophony, bronchophony, and whispered pectoriloquy. And the tactile fremitus would now be increased. For other common lung diseases in atelectasis with partial lobar obstruction, the affected lung is collapsed, but there is still the presence of a proximal airflow towards the affected lung, hence acting like a consolidated lung, producing dullness on percussion. There are also bronchial sounds that are heard distally, and an increase in the voice transmission with egophony, whispered pectoriloquy, and bronchophony, and also the presence of fine crackles. On the other hand, an atelectasis with a complete lobar obstruction, there is now the absence of proximal airflow towards the affected or collapsed lung. But there is still dullness and percussion, but because of the impedance of sound, there is now a decreased infremitus, decreased breath sounds, and decreased voice transmission. For pleural effusion, it would present with dullness on percussion, decreased fremitus, decreased breath sounds, and decreased voice transmission, all due to the fact that the fluid can impede sound transmission towards the chest. In addition, a pleural rub sound may be heard, and it is a type of greeting type of sound, like two sandpapers rubbing against each other, and the sound is brought about by the inflammation of the pleural linings, your parietal and your visceral pleura. In pneumothorax, air, just like water in pleural effusion, impedes transmission of sound through the chest. Hence, it has almost similar findings to pleural effusion, but percussion would produce a hyper-resonant sound or a tympanitic sound. For asthma and COPD, these are both airways disorder, meaning air within the lungs cannot sufficiently be exhaled, especially for severe exacerbations of asthma and COPD due to airway obstruction. Hence, the examination findings for both can be similar, with resonant to hyperresonant on percussion, decreased breath sounds on severe cases, with wheezing and possible crackles. Both can have decreased tactile fremitus and transmitted voice sounds. Now that we have finished with the physical examination, let's focus on two of the most common respiratory complaints, namely your cough and hemoptysis. The other listed symptoms would be discussed by your other lecturers in the future. Cough is the most common complaint for which patients seek medical attention, not only among pulmonary specialists, but also among general practitioners. And its essential function is to protect our airways and lungs. And without proper functioning cough, patients are predisposed to having recurrent infections, atelectasis, and respiratory compromise. On the other hand, excessive coughing can also be detrimental and cause complications such as vomiting, syncope due to decreased venous return, muscular pain due to muscle spasms, or rib fractures due to the severe muscular stress, which is usually seen in young adults rather than in the elderly. There may be a presence of back pain, abdominal or inguinal hernia formations, urinary incontinence every time the patients cough, or the presence of pneumothorax due to repeated increase in the intraalveolar pressures. Cough can be voluntary or involuntary. The voluntary cough is initiated in the upper cortical brain regions and uh, can bypass the brainstem. Therefore, a patient with a damaged brainstem, despite having no cough reflex, can still cough voluntarily. But what we will be focusing today now is on the involuntary cough, and it is initiated by the stimulation of your chemical and mechanical receptors connected to your vagus nerve, trigeminal nerve, and your glossopharyngeal nerves. And these three nerves form the afferent limb of your cough reflex. Specifically, your vagus nerve innervates the larynx, the tracheobronchial tree, the lower parts of the oropharynx, and also the tympanitic membrane and the external auditory meatus. That is why when there is manipulation of the external auditory canal, some patients would tend to feel the sensation of coughing through the simulation of the Arnold's nerve. So when these receptors are stimulated, the sensory inputs goes up and are integrated into the brainstem. So from there, the output from the cough generator within the brainstem are relayed back to the motor neurons of the respiratory muscles, eventually triggering the cough. However, some sensory inputs that enter the brainstem are also relayed up into the higher brain regions. That is why there is evidence of sensation of the urge to cough even before the actual coughing happens. And when we feel that type of sensation, sometimes we can override temporarily the cough reflex. The sequence of events in cough reflex have three major phases, namely your inspiratory, compression, and expiratory phases. So in the first phase, there is an inflow of air leading to lung expansion. And when your lung sufficiently expands, it equates to a stronger elastic recoil that can aid the cough process. And in the second phase, the glottis is closed while expiratory muscles contract. And during that time, there is no net flow of air, thereby creating an increase in alveolar pressure. So in the last phase, once sufficient pressure has built, there is a sudden opening of the glottis with a rapid expiratory flow and thereby producing the cough sound. So both the increased driving pressure and the narrowing of the airways will help or aid in the expulsion of the mucus and the other particulates in your airways. There are a lot of reasons for ineffective cough mechanics. The problem may lie on the expiratory muscles being weak or having pain on the chest or abdomen, which are the foremost reason for an impaired cough. The other causes may involve the central nervous system or the peripheral nervous system, specifically those with the massive cerebrovascular infarcts with massive cerebral edema causing high intracranial pressures, or patients with Guillain-Barré syndrome or myasthenia gravis. And there may be also an abnormality in airway secretions, ciliary dysfunction, or structural abnormalities in the airways that can also lead to cough inefficiency. Cough has multiple etiologies, and there are some of examples seen here as labeled to be exogenous, including inhalation of toxic substances or aspiration of a foreign body. Drugs can also cause cough, typically your ACE inhibitors, usually used for hypertension. And the effect of the ACE inhibitors would halt the metabolism of your bradykinin, which sensitizes your cough receptors. So for patients recently started on ACE inhibitors, regardless of the dose, that eventually develop cough, you may try a trial of holding the medication for 1 month while replacing it with another antihypertensive medication. Other causes are found inherently in our body and can be generally be divided into pulmonary and extrapulmonary causes. The pulmonary cause would include any type of infection in the airways, whether viral, bacterial, or fungal, any type of disease that causes inflammation, contraction, compression, or infiltration of the airways, parenchymal diseases such as pulmonary fibrosis or interstitial lung diseases, vascular problems such as your pulmonary embolism or vasculitis, tumors, whether primary lung malignancy or a metastatic lung disease. Extrapulmonary systems can also induce cough, most commonly the presence of a gastroesophageal reflux. And the acid reflux can go up not only in the distal parts of the esophagus, but also towards the pharynx and possibly into the lung. And when gastric contents are aspirated into the lung, it can cause intense inflammation in the lung parenchyma, producing your so-called chemical pneumonitis, which can mimic pneumonia clinically and radiologically, but antibiotics are not indicated in cases of chemical pneumonitis. So when a patient comes to you for cough, your history should focus on the following. You need to determine the severity of the cough by taking note of the duration, whether it be acute, subacute, or chronic. Acute if it's been less than 3 weeks. 3 to 4 weeks, it will be labeled as subacute, but more than 8 weeks, it will be already be chronic. And you also look for the presence of any complications due to excessive coughing, as discussed earlier. You also assess the possible causes of chronic cough. You look for any presence of other pulmonary symptoms that point to a certain disease, like allergic rhinitis, severe pneumonia, or the presence of an underlying condition such as asthma or COPD, bronchiectasis, or lung abscess. Would there be any other systemic extrapulmonary symptoms in your patients that point to other causes, such as malignancy, heart failure, renal failure, or gastroesophageal reflux disease? Are there risk factors that increase the risk of other diseases, such as your AIDS, HIV, lung cancer, pulmonary embolism, or interstitial lung diseases? So for every assessment for a patient with cough, regardless of the duration of the symptoms, investigate actively for these red flags. This way, it would be easier for you to detect more serious, possible life-threatening pulmonary diseases that would warrant an immediate investigation and management. These red flags would include a blood-tinged sputum, a patient with a smoking history, adults who are in the elderly age who have a history of smoking, a prominent dyspnea, hoarseness, the presence of systemic symptoms, trouble in swallowing when eating or drinking, the presence of vomiting, and a history of recurrent pneumonia. These are all red flags that you need to be actively looking for in every patient that you see that comes in for cough. The next slides that I will show you will cover the most common causes of cough, whether acute or chronic. This must be always be part of your differentials for any patient coming in for cough. We have 4 examples here causing acute inflammation, namely your laryngitis and acute bronchitis. Both present typically with dry cough and a variably can be productive. Most are viral in origin and fairly self-limiting in its disease course, being mostly due to viral infections. So you can have prodromal symptoms of colds, anosmia, and throat itchiness. Generally, they have no fever, but they can have a feeling of malaise. Pneumonias caused by either viruses or bacteria can present with systemic symptoms, however, like fever and malaise, and can have other respiratory symptoms such as dyspnea and chest pain. Cough in viral pneumonia are typically dry. On the other hand, sputum is produced in bacterial pneumonia, whether be it mucoid, purulent, or bloodstream. Both can be preceded by a viral upper respiratory infection, making the pneumonia an extension or progression of the initial infection or a complication such as a superimposed bacterial infection. Here is now a list of the causes of chronic inflammation of the airways and lung. First off, your postnasal drip, or otherwise called the upper airway cough syndrome. It is caused by inflammation of the nose and sinuses, and the patient can present with frequent throat clearing, sneezing, or rhinorrhea. The sputum can be mucoid or mucopurulent, and it is highly associated with the presence of allergic rhinitis. Chronic bronchitis, on the other hand, is associated with a prolonged history of smoking causing airways disease, often with wheezing and dyspnea. Sputum can be mucoid, purulent, or bloodstreak. And by guidelines, its definition, the cough must be productive and persistent for at least 3 months per year and for at least 2 years consecutively. Bronchiectasis is the dilatation of the distal airways, which are caused by your recurrent infection or inflammation of the airways. And the cough is usually longer than 3 months and is persistent. Sputum produced can be mucoid, but can be purulent or bloodstreak if there is a superimposed infection. Pulmonary TB. It is one of the most common causes of chronic cough in developing nations, including our own. And a suspicion of pulmonary TB arises when you have a patient who has had cough for at least 2 weeks, with or without fever, chills, night sweats, or weight loss. These are all your prototypical symptoms of pulmonary TB. Initially, patients may present only with dry cough, but the later stages may present with productive cough and systemic signs and symptoms. Lung abscess arises from the progression of aspiration pneumonia, most commonly due to oral anaerobes. Patients can be febrile with other systemic symptoms, and risk factors for the formation of lung abscess would include poor dental hygiene, chronic alcoholism, impaired consciousness, which all increase the risk of aspiration. Sputum are typically purulent and can be foul-smelling for lung abscess. Symptoms of asthma, like wheezing, dyspnea, and cough, can be episodic for mild cases, unlike in chronic bronchitis, wherein the cough is persistent. However, they can be persistent for the severe spectrum of asthma. Asthma can present with episodic cough alone without the other typical symptoms of wheezing and dyspnea, and this is termed the cough variant asthma. This is a common among pediatric population, but not among the adult or elderly population. And the history of allergy and the association of cough with the exposure to triggers of asthma raises the suspicion for a cough variant type of asthma. GERD, or your gastroesophageal reflux disease, as discussed earlier, the acid can go up to the pharynx and into the tracheobronchial tree, which can induce the inflammation of the airways. And when the airways are inflamed and edematous, they can produce wheezing at night, usually when the patient is supine, which can be mistaken for asthma. Additional symptoms could include morning hoarseness, throat clearing, or evening and morning coughing. Often, these patients have a history of heartburn or regurgitation, which strengthen the possibility of a GERD-induced cough. But then again, the majority of patients with gastroesophageal reflux does not present with any cough at all. Lung cancer, whether primary or metastatic, are important differentials for chronic cough, especially if there's a presence of hemoptysis and risk factors for malignancy. Usually, patients may present with dyspnea or weight loss, and the presence of cigarette smoking enhances the risk for lung cancer. It is actually its primary risk factor. Although there are very, very rare cases wherein there is actually no risk factor that can be present. The youngest patient that I've had having a lung cancer was a 23-year-old male, non-smoker, no history of family malignancy whatsoever. He presented initially during the COVID pandemic with pneumonia, and we eventually found out that he had already cancer at the later stages, stage 4. You can also have cardiogenic causes of cough, such as in left ventricular heart failure or severe mitral stenosis, wherein there is extravasation of fluid into the alveoli due to the increased pulmonary pressures. Symptoms related to heart would likely be present in these types of patients, like dyspnea or topnia edema, but these are actually non-specific. A more specific cardiac symptom would be your paroxysmal nocturnal dyspnea, wherein a well patient would lie down at night and after 15 to 30 minutes, the patient would feel like he would be drowning with alleviation of the symptoms when he sits up or stands up. So this is a more specific sign or symptom for a cardiac cause of cough. Pulmonary embolism is primarily a vascular problem wherein an embolus blocks the distal part of the pulmonary artery, causing ischemia or infarct. They most commonly present with an acute onset of dyspnea, tachypnea, tachycardia, dry cough, and chest pain, and can also present with hemoptysis. The embolus that causes this most commonly originates from a deep vein thrombus in the lower extremity veins. So you need to take note of the risk factors for deep vein thrombosis, which can include immobility, a debilitated patient, a bedridden patient, a recent major trauma or surgery, the presence of malignancy or a chronic venous insufficiency, obesity, smoking, contraceptive use, an older age, or pregnancy. So for our female young audience here right now who are taking oral contraceptive pills, never combine smoking with the intake of your OCPs because this will set you up for pulmonary embolism. And lastly, particulates in the air can cause cough, whether chemical and gases in your house, school, workplaces, or around your neighborhood. And latency on the symptom onset can occur, meaning exposure in the morning can produce symptoms later in the afternoon or evening. That is why we ask our patients to be observant all throughout the day of the exposures surrounding the onset of cough, especially if the cough has been chronic and persistent. So these are just a summary of the most common causes of your cough and hemoptysis, but I would recommend that you still read on specific chapters on Harrison's for each of the diseases discussed here today. Last among the common causes of your chronic cough is the cough hypersensitivity syndrome. And this is characterized as a chronic cough triggered by a low level of stimulation, whether be it mechanical, chemical, or chemical triggers. There is a hypersensitivity in the receptors, thereby causing a type of cough hyperreflexia. They may have hypertusia or increased cough sensitivity to a known stimuli, or alopecia or cough in response to a stimuli that does not normally cause a cough. Patients will typically complain of a dry or minimally productive cough, a tickling, irritating sensation in the throat, and the cough can be triggered by laughing, deep breaths, cold air, prolonged talking, or exertion. This is just an approach or algorithm to chronic cough taken from the CHEST guidelines for cough. So your initial evaluation would always include your history and physical examination, and an initial chest x-ray may be needed if the physical examination is unremarkable. If one of the red flags are elicited, then focus investigation, and treatment is needed. And if you are able to elicit a reversible trigger for the cough, such as drugs, smokes, or environmental exposure, then you need to discontinue or avoid them for at least 1 month and observe. If, for example, the physical examination and the chest X-ray show unremarkable results, then you must focus on the three most common causes of your chronic cough, namely the upper airway cough syndrome, asthma, and gastroesophageal reflux. Treat all, if present, for 1 month and then observe. After this, if the cough still persists, then further diagnostic tests are warranted. A high-resolution CT scan and bronchoscopy may be pursued despite having a normal initial chest X-ray. A sputum examination is indicated for chronic productive cough. A bacterial, mycobacterial, fungal cultures might be needed for purulent sputum, and a cytologic examination for clear or mucoid sputum may be needed to exclude the presence of malignancy. Additional testing should always be done as clinically indicated. Do not do blind shotgun testing. So if the initial assessment point towards a gastrointestinal cause, then pH measurement or endoscopy may be indicated. If the assessment points to a cardiac cause, then do your cardiac workup. If, despite all of the investigations and optimal treatment, the cough persists, then consider the possibility of a cough hypersensitivity syndrome, which is a diagnosis of exclusion. Now, let's move on to the other common respiratory symptom, your hemoptysis. Hemoptysis is the expectoration of blood from the respiratory tract, and this must be distinguished from pseudohemoptysis, which can be seen in as much as 10% of suspected hemoptysis cases. And pseudohemoptysis usually includes bleeding from the nasal cavity, termed epistaxis, or from the GI tract, termed hematemesis, or in the other parts of the upper airways. Thankfully, history and physical examination can easily differentiate between these diseases. Same goes as when you have a patient complaining of vomiting of blood or hematemesis. You need to make sure that the bleeding did not come from the upper or lower respiratory tracts. Hemoptysis is labeled massive or life-threatening if the volume of hemoptysis is more than 400 ml for the past 24 hours, or at least 100 to 150 ml in one instance. Fortunately, it only accounts for 5 to 15% of cases of hemoptysis. However, it carries a substantial mortality rate of 9 to 38%. And the high mortality rate depends actually on the acuteness of the bleeding, the ability of the patient to to protect the airway by coughing out the blood, and the extent of the comorbidities. Patients actually rarely die of blood loss, but rather at a risk of dying due to asphyxiation or suffocation from the blood filling up the airways and air spaces. It's like drowning in your own blood. Your lungs are supplied by two arterial circulations, namely the pulmonary and the bronchial artery circulations. The pulmonary circulation carries the deoxygenated blood to the alveolar levels for gas exchange. Therefore, it has a low pressure within its vessels. On the other hand, the bronchial circulation provides oxygenated blood to the lung structures, and it has a high pressure within its vessels, and it is the most common origin of your hemoptysis, almost 90% of them. The most commonly involved area of the lung would be the airways, followed by the lung parenchyma and the vessels. And the most common cause among industrialized nations are respiratory infections, whether viral or bacterial, followed by cancer and bronchiectasis. However, in developing nations such as in the Philippines, pulmonary TB is the most common cause of hemoptysis. These are the examples of the causes of hemoptysis divided by its general location. The airway diseases, cancer, which should be always be ruled out if the patient has risk factors such as smoking, elderly, and male. Acute bronchitis is the most common cause of blood-streak sputum if there are absent risk factors for other diseases. And acute bronchitis is typically viral in origin. Under your vascular diseases, pulmonary embolism can also cause hemoptysis. And in parenchymal diseases, under this category are the drugs that you need to ask for if the patient is taking any anticoagulants or antiplatelets, and also ask for any underlying bleeding disorders. This is an algorithm taken from Harrison's on how to approach hemoptysis. And the first step is always to rule out pseudohemoptysis. After which, once we have confirmed hemoptysis, we need to determine whether the hemoptysis is life-threatening or massive versus a non-life-threatening or a non-massive hemoptysis. So for massive hemoptysis, focus is always to stabilize the patient first and control the airways. And this needs to be a multidisciplinary approach, usually involving your pulmonologist, intensivist, thoracic surgeons, and your radiologist. On the other hand, for non-massive hemoptysis, focus is toward identifying and correcting the underlying cause. And if there are no risk factors for malignancy or other abnormalities, then treat the suspected underlying disease and observe. However, if there is a risk for malignancy or other abnormalities, then you need to do your initial diagnostic test if warranted. If with unremarkable initial diagnostic test, then you may proceed with chest CT scan. Eventually, bronchoscopy can be done if the chest CT scan results are unrevealing, namely to primarily exclude the presence of bronchogenic carcinoma. This is a typical setup for bronchoscopy, and usually a flexible scope is inserted through your nose or mouth and eventually enters the glottis, then into the target lung segment. And the tip of the scope actually lies the camera with the image being projected beside the operator for easy viewing. And instruments can be inserted inside the scope, and the instruments can be used for biopsy or other procedures that may be needed. This is a view from a bronchoscope looking directly at the carina coming from the trachea. So as you can see at the 9 o'clock position is the entry to the left main bronchus, and at the 3 o'clock position is the entry to the right main bronchus. And blocking both entries are the presence of your blood clots. Here are samples of the blood clots that were removed from the bronchial tree, and they resemble the configuration of your airways. And if these blood clots weren't removed, the patient may have died of asphyxiation. So that would be the last slide, and I hope this lecture gave you a broader knowledge in handling patients with cough and hemoptysis. But I highly still recommend to supplement this lecture with further readings of your Harrisons and Bates. And if you have any questions or clarifications, please share it with us through the text box, and I'll be answering them in a few minutes. Thank you for your attention.
Recording stop.